Her topic is on the enhanced recovery after surgery, EVAS protocol for upper gastrointestinal cancer surgery. Floors are yours. Thank you.
Yeah. Very good morning, and thanks, Professor Karin, for the introductions. So next, I think I'm just going to share on slightly different topics in the next 20 minutes or so on enhanced recovery after surgery, ERAS, for upper GI cancer surgery. I'm a surgeon. I'm upper GI surgeons in IKN. So hopefully I can share a little bit from my perspective, not so much on the surgeon point of view, but how we deal with our patients to help them to survive through surgery. So I have no disclosure for this talk. And this is my outline. I'm going to touch a little bit on the surgical stress response because this is the basis of ERAS and our local burden for upper GI cancer. How do we target some of the modifiable factor so that we can achieve a better outcome for patients? And of course, the practice of ERAS and prehabilitations has its own limitations. So the moment a surgeon lay a knife onto the patient, there will be a lot of humoral or immunological response being elicited. And this response will lead to a series of pro-inflammatory cytokines being released into our body, and therefore leading to a hallmark or metabolic hallmark of insulin resistance and body catabolism. And this response is supposed to bring good to our health because it's supposed to help us to return to homeostasis. But however, when it is too prolonged or it is too much or too heightened, and it will lead to a poor surgical outcome. So if you look at the interest between, from the surgeons or clinicians or researchers, looking at the relationship between outcome and surgical stress response, you know that the numbers of studies are actually getting more and more over the years. And it purely just tells us that if we know to do something about the surgical stress response, if we know what to deal with it, we can get a better outcome. So this is why ERAS itself is mooted back then in 1990s by a colorectal surgeon named Professor Henry Keller, that he tried to start changing some of the traditional, conventional perioperative way of dealing with surgical patients in open colon surgery, and he managed to bring down the length of stay from 10 days to just purely 2 days. He gathered a group of interested clinicians, and they start to look at what they can do better to help patients survive through a surgical journey. So they realized that it's not just one isolated item, but they need to change a few protocol during the perioperative periods. And as more data are being collected and recorded and also analyzed, they managed to produce or publish the first consensus guideline in colorectal surgery, and subsequently form a society to publish, and with the international effort, they publish more this international guideline in an open access way to share with other people, not only colorectal surgery, but also others, including upper GI surgery, which the guidelines are published much later. So generally, the concept of ERAS, it's multi-modal, multiple element. It involves multiple team and multiple phases, at the perioperative periods. With just one aim, we want the patients to go back home earlier, they recover faster, and also they return to their functions earlier. So we want to have less catabolism for this group of patients. So it is not just a standardized perioperative protocol, but it is a strategy. It is a metabolic strategy to help surgeons to allow patients to recover better after surgery. It has proven its role in abdominal surgery, thoracic surgery, and even pelvic surgery. But what about in upper GI surgery? If you look at the data, high quality data show that it reduced the length of stay of a patients who have underwent esophagectomy and gastrectomy. Reduced lung infections, definitely, and this is one of the main complication that we have after we do either esophagectomy or gastrectomy. It's more than 50 or 60% of our local populations will have this pulmonary complications. So reducing the lung infections by implementation ERAS is very important. One of the contentious findings that we found, the risk of admissions may be increased, especially in open gastrectomy. I think this really it's due to the post-gastrectomy dietary adaptations, because a lot of time patients survive through the initial perioperative phase. They do not have complications and they go back home. But after surgery, they do not have a stomach, they do not have a reservoir. When they eat their normal diet, they need to change their habit. And that is why when they can't adapt well, they might be readmitted again, even they have survived through the immediate perioperative period. What about the role of ERAS in upper GI cancer surgery in a local context? Let me just share with you, this is our local protocol. Okay, it is just to show to all the delegates here that this is how we are very stringent about every single steps. So on the left column, you can see that there are multiple elements that we are targeting to help patients, from nutrition, physical exercise, to perioperative these elements such as antibiotics, drains, and until the patient is discharged. And the top row, you can see that those are the time frame that we want our team and we wish that our patient can achieve in order to get a good and also the optimal discharge of a patient. So coming back to this slide, what we did or what we are doing now, we are doing this minimally invasive surgery, okay, for both stomach and for also esophageal thoracoscopic. We are trying to go away from opioids because of the side effect. We do epidural. If the epidural is contraindicated or failed to be inserted, then we will put continuous wound infiltrations for the means of continuous infiltrations of local anesthetic to reduce the pain. We also, work well with our anesthetic team. We do not use urine output and we run a lot of fluid during surgery. We want to control the fluid tightly by the means of hemodynamic monitoring. We are using flow track. But these are not the things that I'm going to boast to all the delegates here. These are the wonderful things that we are doing. The thing that I want to raise, hopefully concern of everyone, as a surgeon, I know this is not so much of a surgeon thing, we talk about technology, about technique, but to bring back, looking at our team's survivorship, we need to start looking at the basic thing for our patients. Okay, so I would want to share a little bit on the importance of nutrition and also exercise along the way of ERAS to help our patients to survive through surgery better. So we want good outcome for the patients. If you look at the number 3, we practice ERAS, so we reduce the surgical stress. Okay, we deal with, we use minimally invasive, we use technology, we use good technique, we work well with our anesthetists, we have a better quality of surgical care for the patient. But what about the pre-op patient's conditions? If you look at, you remember just now what Dr. Saiful mentioned, a lot of our patients present to us late, at a late stage of cancer. This is what they are going to have. They are malnourished, they have not enough muscle, they are frail, they have very poor reserve. So if you want to bring this group of patients to a surgery, to go through a major surgery, you are going to ask for trouble. Gastroesophageal tumor or upper GI tract cancer lead the chart in this malnutrition chart, whether they are metastatic or non-metastatic disease. In our local setting, when we look back at our patients, 85% of them are malnourished before we bring them to OT to do gastrectomy for gastric cancer. And we know all sorts of negative impact will happen to them. They cannot complete their adjuvant, and they have a lot of toxicity, they have a lot of complications. And more so, sadly to say, as expected, our upper GI cancer patients come to us at the late stage if you compare to other countries. Japan, they have one of the highest, including Korea, but their stage is so early. Ours is at the stage 3 or even stage 4. So you can expect our survival is never good. If you look at the turquoise arrow, that is a stage 3. We can only expect 20% of them survive through 2 years. Stage 4, only 10% of them could possibly survive through 1 year. So if you want to bring this group of patients to surgery, you cannot just do ERAS. ERAS minimize the stress response, yes. Studies have shown enough that it will reduce the surgical complications. So now, to all the delegates who are clinicians, who are surgeons especially, we need to start moving backward a little bit to look at the physiological reserve of our patients, to do something what we call a prehabilitations to improve their survival. So this concept is not something new as compared to ERAS. ERAS, it is mooted back in 1990s. This has been there in the market, in the medical field for more than 10 years. It's to increase the patient's reserve, to precondition them, we provide them with nutrition support, we want them to do exercise, we support them psychologically so that they can return to their function after surgery faster. So if you look at this, we need to start integrating nutrition, not just talking about the perioperative periods that we do wonderful job during surgery but the patient don't survive. We need to start supporting them even way before surgery, way before they are admitted, and we are trying to collect small gain at every step, before surgery, when they are admitted, after surgery, and after discharge. By collecting all this small gain, only then we are hoping that we can bring a more clinical, meaningful outcome for the patients. And this is in line with the international guideline. If we see that our patients is not good to begin with, they are malnourished, we have to stop thinking about surgery straight. We have to make sure that we help them, prehabilitate them for 1 to 2 weeks before we do the surgery. Another examples of our local protocol. So what we do for the patients, we really screen them through strictly. They will have to achieve the target. Okay, but of course this is just an excerpt of one of our chart. And of course post-op, they will need to achieve target because otherwise we are running into trouble. And I would really want to urge everyone who manage cancer patients, besides surgery, besides chemotherapy, radiotherapy, or wonderful immunotherapy or target therapy, I must stress again and again, I think just now a previous speaker mentions about healthy lifestyle. Exercise is medicine for cancer. There is role in prevention and there is role for patients in terms of survival. Yes, of course, as surgeon, we do practice some prehabilitation. So we want patients to do, some exercise, whether it is aerobic exercise or, resistant exercise. And of course, as an upper GI surgeon, we must tell patients to do proper breathing exercise in terms to help them, in terms of recovery after surgery. But exercise, it's medicine. So don't forget about these basic things besides talking about the hi-fi treatment. When we look at how we help our patients, we push the nutrition, we help them, we talk to psychologists, and as Dr. Saiful mentions, we have good psychology support in IKN, and of course, we push them to do exercise. Can they do better? Yes. This is a study, we did it in IKN and on our own patients. You do better for them, they will be better. So this graph is just to show how we can help our patients to pull through a major surgery. The practice of ERAS, as I mentioned earlier, it's not adequate. Whichever operations that you do for the patients, the functional status will drop immediate after the surgery. So in a conventional way, they recover, but they probably recover very slow and very late. With ERAS, the immediate perioperative period protocol, you help the patients to recover faster. But if you prepare the patients much earlier, you prehabilitate them, then they could recover much better compared to ERAS. Of course, there is its own gap and limitations. Looking at the system that we have, our patients don't come in, in the same size and the same shape. Some of them come in very catatonic, very thin, and some of them are obese, but they do not have muscle. We call it sarcopenic. Even stomach and esophagus cancer, they don't behave the same. So with that different systems, what we can achieve in Institute Cancer Negara might not be easy to achieve in other hospital or other institution. So ERAS itself, although it is a perioperative pathway, but it is something that you can modify according what the resources that you have. All right. And ladies and gentlemen, as a conclusion to help our patients survive through their cancer journey, as a surgeon, definitely I need to stress again and again, enhanced recovery after surgery protocol should be, as it's the standard pathway. But because it doesn't really negate all the complications, so we have to start thinking of a recovery of the patients way before surgery, not just after surgery. This is what I should do to help the patients to recover. And one of the things that I think remind all of us also, cure doesn't mean care for patient. So what we need to do sometimes is also empower, educate our patients so that they can modify their behavior, their way of thinking. Because as doctor, we want a cure for patient, but sometimes patient will not feel it as a cure. What they want is actually care. So again, and lastly, if we prepare the patients better before the surgery, they are going to come out from the surgery better. With that, thank you very much.
I now invite Prof. Chan to present a small token of appreciation to Dr. T. Oh, sorry, questions. Sorry, we'll have the Q&A, sorry. I assure you we'll give you the token, but we'll just take questions first. Sorry.
Hello, good morning. My name is Sharifah. I'm just GP, but my GP is focused more on health screening. So I believe that you said ERAS must start at least 2 weeks before surgery. So if I could, if let's say I have patient based on my clinical judgment is very, very highly suspicious of cancer and need of surgery, in your opinion, at my primary care setting, who should I refer to straight away for the nutrition and physical exercise? And is it like I can refer to any dietitian or any physiotherapy center, or there are better specific place to start?
Right. I think I work in IKN. Although I'm a general surgeon, but I mainly deal with upper GI cancer patients. So if you have any upper GI cancer or suspicious of that, talk to me straight. Then we will deal from there. Because sometimes I think when the patients have certain red flag symptoms, the issues with our local setup is, if they go to private, yes, they get a lot of things done very fast. But if they come to some clinic kesihatan and they have to wait for a very long time, and we do not want them to go to this clinic appointment, that clinic appointment, at the end of the day, there are a lot of time wasted. If anything red flag regarding upper GI, I think I'm happily to give you my contact. You can always call us, come to our clinic straight. Usually I will not give TCA 2 months or 2 weeks, Sometimes the same week, if we have slot, same week, even we have no slot, we will actually ask them to come to see us. Then we can do the necessary thing. Because screening for cancer, symptoms itself is not very specific. We will never trust the symptoms. Tumor marker, even though it is some are more specific to certain cancer, but it's not. We need some imaging, we need some endoscopy to help us to reach the diagnosis early. Then only then we can talk about the treatments. But before the treatment, yes, in IKN, I think we have good team of dietitians. We also have physiotherapists. So if it is something related to upper GI, call me straight, and we'll see the patients quite immediately. Then we will sort out from there onwards. We really want to prevent the waste of time, for the patients to go through this clinic and that appointment and that appointment. Yeah.
Any other questions?
Thank you. Good morning, Dr. T. My name is Faiza. I'm from Monash University. I'm working on research on gastric cancer and anti-cancer treatments. I want to ask you two questions. How often do you see your patients who have gastric cancer and they are obese? And the second question is, what kind of complications that do you see in these obese patients pre and post-surgery? Thank you.
Okay. I think obesity, of course, is getting more and more common in our country. If you get an early stage cancer, we do see patients with obesity. Esophageal cancer, nowadays, if we are looking at junctional cancer, more so because of the reflux and because of the because of the reflux due to obesity, we do see obese patients come with upper GI cancer itself. But late stage, usually none. Okay, and obesity is not the best indicator for us to judge whether the patient is malnourished or not. It's the muscle, okay, it's the quality of the muscle. So we are looking at sarcopenia rather than just a BMI, because BMI decide obesity in our local context. So I hope that I answer your questions, number one, because it really depends on the stage of the disease. And sometimes if we have patients who present to us in the bleeding fashions, hematemesis, they usually come a bit earlier. But those who have obstructive symptoms, a little bit of obstructive symptoms, they tend to come late because our stomach, our esophagus can really stretch. Okay, so that is a different spectrum of these presentations. And sorry, your second question is? The complications of treatment. Pre and post surgery. Okay, as I mentioned earlier, obesity is just how a patient appear in front of us. But beneath the body, there might be just fluid, there might be just fat, or very little muscle. So the complications account, if the patient have very little muscle, they tend to have more complications. But obese patients, sometimes they can have adequate muscle itself. Those are the patients who would have less complications, whether it is surgical complications or chemotherapy complications. So the shape itself outside, the BMI itself doesn't mean much to us. It's the body composition that means more to us, actually. I hope I answer your questions, yeah.
I think we have time for one last question.
Okay.
Hi, my name is Maria. I'm a staff nurse from National Cancer Society. There's one question I would like to ask is there any cheaper way besides endoscopy to detect upper GI cancer? Because we have IFOBT to help to detect colon cancer.
Yeah. Unfortunately for upper GI cancer, none. Yes, we have barium swallow, but I think none of our radiologists are so into barium in detecting early upper GI, esophagus or stomach. So the best way it is still endoscopy. And of course, plus minus with some of the imaging, because sometimes if it's small tumor, you might miss from imaging like CT scan. So the best is still endoscopy. That's why the access to endoscopy is a problem to us. And the quality of the endoscopy is also a problem to us in terms of early diagnosis for upper GI cancer. Yeah, but that unfortunately no specific tumor marker itself. Yeah.
Thank you so much for the questions.